So in one way or another, I'm always either following the robot or running away from the robot. So today I was intervened by the robot. If you turn the lights down. So my charge was to talk about some novel technologies or some further data on technologies we've started discussing in the last year. So I'm going to talk about a couple of things to be quick. I'm going to give you the 14-month results on the bipolar RFA laparoscopic. I'm going to mention electroporation for you and give you an update on the North American HIFU. I'm going to talk to you about intravenous transdermal flow cytometry for detection of circulating tumor cells, one of the trials we started, and this has all been discussed already, so I'm just going to skip that. So bipolar RFA. Worth to separate for those of you who have never used a bipolar system, monopolar from bipolar. If you're using a monopolar system, your needle is just a component of the circuit, and the amount of energy required to burn a tumor is based on the inverse square law, which means the further away you're from the generator, the more energy you need to actually heat that tumor. And one of the problems is that your energy is being delivered around your catheter. Bipolar systems shoot energy in a line of sight direction between two different antennae, so all of the energy is directed between these two polarities, so you can reduce the amount of time that you need significantly, and there is no energy being spread outside of that field, so injury is less common. I'm a little less certain after yesterday whether or not there is a role for bipolar in my world anymore after Eddie's talk, but these are typical unipolar electrodes. And all of these different electrodes have been developed in different ways to try to increase the amount of energy that's delivered. And for difficult areas to get those electrodes to, different shapes of these probes have been designed. So bipolar systems can give you larger burns, quicker burns, and they can minimize collateral thermal damage. And the convective heat loss is also mitigated. This is what a bipolar system looks like. It's just basically two antennas, and the energy is delivered entirely between these 2 points right here. If you look at an EFA of the energy delivered here, what you see is that in a monopolar system, the energy has to radiate from each point of energy delivery, and it becomes one over time. In a bipolar system, the energy starts hot from the sides and comes towards the middle. The big limitations with monopolar is that you get charring, roll-off, impedance. So it takes more and more energy for you to get the energy to that point, and basically your machines can't do it. So this is our 14-month experience, and we were the first people in the country to get access to this laparoscopic bipolar device. And we've done 26 burns in 17 patients, and here's our results. The vast majority of these were colorectal cancer. And of the 12 that were here, 6 of them were ASA3, greater than 80 years old, with synchronous colorectal liver mets. So the original intent was to do a bipolar RF as a staged definitive resection. 5 of those patients have subsequently undergone a proper resection with no evidence of tumor in the specimens. There was 1 hepatocellular and 1 adenoma. Let me explain this adenoma. Young woman, 5-centimeter adenoma, left lateral, 2-centimeter adenoma up in segment 4A8. She got a laparoscopic adenoma resection, and at the same time, she got a RFA of that lesion on the right lobe. So that's the reason for doing that. Distribution of our lesions, you can see they're all relatively in good positions, safe positions. So if we look at the lesions that are less than 3 centimeters, 10 of them, our mean burn time is 5 minutes and 37 seconds. If you look at the lesions that are greater than 3 centimeters, which is 16 of them, and the range is up to about 5.5 centimeters, the median burn time is 6 minutes, 17 seconds. So all of our lesions, our mean ablation time, which is not significant between size, is 6 minutes. So we can do a 5-centimeter ablation with a bipolar technology in 6 minutes, consistently, and that just beats every other system that's in the water out there. No financial relationship to the company, by the way. So in 5 of the 17 patients, we've gone back and done a definitive lobe because they had synchronous disease, and we have found no evidence of viable tumor in the previous ablated areas. So now we're starting to think that in these ASA3 greater than 80-year-old patients, we will probably be doing a study looking at these high-risk patients for salvage resection as opposed to whether or not we need to do that. I'm going to skip the video. So most efficient out in the literature. Okay, so electroporation. How many people